I think it's one of the thinnest and slimmest CGR that I'm going to be presenting. Probably. So good afternoon, everybody. From the Department of Gynae 2. Actually, this was Gynae 3, but we've been upgraded to Gynae 2 in the new terminology over the last month. So from the original Gynae 3, now Gynae 2, we present our CGR on use of anticoagulant therapy in pregnancy. By virtue of being a high-risk pregnancy referral unit, in our department, we rather have a flair to use prophylactic anticoagulants. But when we look at therapeutic uses, I think it is a humongous, strain on our services. Needless to say, the stakeholders and the partners who refer us patients and also help us manage is enormous. So today we take you through a CGR on the multidisciplinary team management to share the nuances and the challenges that we face in managing women who get therapy, i.e. in terms of therapeutic doses of anticoagulants. So this CGR is being spearheaded by Dr. Vidushi Kulshresha, who is an additional professor. Again, partnered, and our stakeholders are from cardiology, Dr. Ambuj, from hepatology, Dr. Shalimar, and Dr. Mukul from the Department of Hematology. And of course, our anesthesia colleagues will be joining. To take the seminar through will be started by Dr. Tanisha, our junior resident, and Dr. Shubhi, ISR, and another faculty colleague, Dr. Saloni. So I would request Dr. Tanisha to start the CGR.
Good evening, everyone. Unit 2 Obstetric and Gynecology will be presenting clinical grand rounds on the topic Walking the Tightrope and Experience of Anticoagulant Therapy in Pregnancy. Our CGR will be covered broadly under 4 headings: Introduction, our experience, anesthetic perspective, and discussion. Pregnancy is a hypercoagulable state. In comparison to the non-pregnancy state, there is 4 to 5 times increased risk of thromboembolism in a pregnant female, the predisposing factors of which can be the inherent prothrombic state in pregnancy and the underlying disease. It has been observed that 80% of these thromboembolic events in pregnancy are venous. Anticoagulation in pregnancy has been considered as a double-edged sword, the underdosing of which can lead to thrombosis, which has been reported in 4.7% of the cases, and overdosing can cause bleeding, reported in 23% of the cases. The normal physiology of pregnancy promotes coagulation state. There is increase in fibrinogen factors 7, 8, 10, von Willebrand factor, plasmin activator inhibitor 1 and 2, decrease in protein C, and no change has been observed in factor 2, 5, 9, protein C, and antithrombin. We all are familiar with the virtue triad of thrombosis, and in pregnancy, all the 3 components, stasis, vascular damage, and hypercoagulated blood are increased. Let's move on to the indications for anticoagulation in pregnancy, which are broadly divided under 3 categories: heart disease with mechanical prosthesis, treatment of acute venothromboembolism disorders, and prevention of venothromboembolism. The prophylactic dose of anticoagulation has been advised in antiphospholipid syndrome, inherited thrombophilia, medical comorbidities like SLE, IBD, nephrotic syndrome, prolonged immobilization, sickle cell disease, and the assessment via risk scoring provided by the RCOG. The therapeutic dose has been advised in mechanical prosthetic heart valve patients during treatment of acute venothromboembolism, patients of atrial fibrillation, and patients of extrahepatic portal vein obstruction and hepatic vein outflow tract obstruction. The drugs used for anticoagulation are mainly oral anticoagulants, which includes warfarin and acetrom, and heparin compounds, mainly unfractionated heparin and low molecular weight heparin. The dosing regime of heparin compounds are present in the therapeutic and intermediate and prophylactic dose, whereas the dosing of oral anticoagulants is based on the target PTNR range. There are some unique considerations in pregnancy about these drugs. The main concern for oral anticoagulants are the concern of fetal safety as they cross the placenta and are teratogenic. Hence, all women in the first trimester during organogenesis are advised to switch over to heparin compounds. Talking about the heparin compounds, there are 40 to 50% increase in the maternal volume, renal excretion of heparin compound, and increased protein binding, which leads to shorter half-life and lower peak plasma concentration of the compounds. Hence, while using unfractionated heparin, there is necessity of increasing the dose and frequent dose adjustments are required, which is done by APTT. Same is the concept with low molecular weight heparin. We have to use adjusted dose and require monitoring by activated factor 10 levels. Also in the peripartum period, as there is unpredictable onset of labor and there is need for neuraxial anesthesia, this poses again problem during the switchover. This is the protocol which is advised by AHA during switchover on patients on anticoagulation therapy. The patients are advised to be admitted at 6 weeks of gestation. After documenting of fetal cardiac activity, patients are advised switch over from warfarin to heparin compounds, either unfractionated or low molecular weight, till the period of organogenesis, that is till 12 weeks of period of gestation. The heparin should be maintained in the target APTT value, which is twice the normal, and the value of anti-factor 10A during LMWH monitoring should be 0.8 to 1.2. After completion of organogenesis, patients are advised to switch back to warfarin and the INR should be in the therapeutic range, that is 2.5 to 3.5. As the patient reaches 36 weeks, it is advisable to stop warfarin as there is no immediate reversal available for warfarin, and patients should be start on heparin as we have antidotes available for heparin. The warfarin should be stopped 6 hours before labor and should be restarted again after 6 hours in normal vaginal delivery and 24 hours of cesarean delivery. After starting heparin, we have to omit heparin after overlapping with warfarin once the target INR is achieved. So summing up the introduction, the prophylactic dose does not pose many concerns, but the therapeutic anticoagulation is definitely a challenge in pregnancy, for which a multidisciplinary approach is required to manage the pregnant woman. This approach requires a multidisciplinary team composed of obstetrician, maternal fetal medicine specialists, hematologists, neonatologists, anesthesiologists, gastroenterologists, and cardiologists.
Good afternoon, everyone. With this background, we begin with our CGR on therapeutic anticoagulation in pregnancy, walking the tightrope. It is a study of retrospective data over 5 years, which was collected from January 2019 to July 2022. Total number of patients on anticoagulation were 183, and out of that, 46 patients were receiving a therapeutic dose, and 137 patients were receiving a prophylactic dose. The mean age of our data was 26 years. The mean BMI was 23.8. The mean gravidity was 2.15. Out of that, 67.4% patients were multigravida and 32.6% patients were primigravida. In respect to booking status, 72% patients were booked with us in the first trimester, 24% patients were booked in the second trimester, and 4% patients were unbooked. The main indications for therapeutic anticoagulation in our data were prosthetic heart valves. 76.1% patients were receiving therapeutic anticoagulation for that. Other indications included hepatic vein outflow tract obstruction, history of DVT or CVA, and acute DVT in the index pregnancy. Preconceptional anticoagulation. Out of the total 46 patients, 40 patients were on oral anticoagulants. Out of that, 32 were receiving warfarin. Out of that, 22 patients were receiving warfarin in a dose of less than 5 mg, and 8 patients were receiving warfarin in a dose of more than 5 mg, and 8 patients were on acetron. 2 patients were on low molecular weight heparin, and 4 patients were not receiving any treatment. The 4 patients that were not on anticoagulant therapy during the preconceptional period was because the first case had acute deep vein thrombosis at 13 weeks. She was also known case of antithrombin 3 deficiency, and she was started on therapeutic anticoagulation after this incident. Second case was known case of rheumatic heart disease with mitral stenosis with history of CVA. She was booked late with us at second trimester on referral from cardiology. The third patient, she had history of mitral valve replacement, but she was non-compliant with her cardiac medications and was booked late with us at the in the second trimester. And the fourth case, she was also known case of rheumatic heart disease. She came to casualty at 17 weeks in the index pregnancy, and dual valve replacement was done in the second trimester at 17 plus 5 weeks of gestation. Now coming to the first trimester switchover, out of the total 42 patients who were on oral anticoagulants, 32 patients were on warfarin. Out of that, 8 patients continued to take warfarin during the first trimester. 6 patients were switched over to low molecular weight heparin, and 18 patients were switched over to unfractionated heparin. Now coming to the patients who are receiving acetrom, 8 patients were on acetrom. 3 patients continued to take acetrom during the first trimester. 4 patients were switched over to low molecular weight heparin, and 1 patient continued unfractionated heparin. And the 2 patients that were on low molecular weight heparin continued to take low molecular weight heparin in the first trimester. Now coming to the second trimester anticoagulation, out of the 46 patients, 37 patients who were on oral anticoagulants continued that during the second trimester, and 9 patients were on low molecular weight heparin. In regards to the third trimester switchover, out of 46 patients that were on oral anticoagulants, 37 patients were on oral anticoagulants, 33 patients were switched over to unfractionated heparin, 4 patients could not get any switchover, and 9 patients that were on low molecular weight heparin continued on low molecular weight heparin. The reason why the 4 patients could not get switchover was because the first 3 patients, they had come to us in advanced labor and progressed rapidly. There was no maternal and the maternal and perinatal outcome in all these 3 patients were good. The last patient was a known case of hepatic vein outflow obstruction tract. She was already underdosed with warfarin, and her PTNR was 1.34 on admission, hence did not require any switchover. The baby of the patient was intubated as the baby had congenital diaphragmatic hernia. Now coming to the epidural analgesia. Epidural analgesia is an important part of labor management even in normal pregnancies. But in heart disease, it becomes particularly significant because all these patients have to be titrated before taking them to the OT. Still, we managed to give epidural analgesia to 64% of our patients, the challenges of which will be explained later by the anesthesia team. Now coming to the mode of delivery, 45 patients who underwent delivery with us, 25 patients delivered vaginally, and 20 patients underwent LSCS. Out of that, 18 patients underwent LSCS for obstetric indications, and 1 patient each for cardiac and hepatic indication. Perinatal outcome, 43 patients delivered a live birth baby, and that is 95.6%. And we had 2 stillbirths in our data, that was 4.4%. The first stillbirth was due to non-immune hydrops, and the second patient, the cause of IUD was not known, but she came to us at 22 weeks of gestation with acute atrial fibrillation and IUD. Now coming to postpartum switchover, the total patients who had for postpartum switchover 44, as 1 patient is still antenatal and 1 patient expired on post-op days 0 of cesarean. 35 patients were switched over to unfractionated heparin, and 9 patients were switched over to low molecular weight heparin. In regards to antenatal complications, the obstetric complications included fetal growth restriction, which was seen in 8 patients, oligohydramnios, which was seen in 8.6% patients, stillbirth, which was reported in 4.3% patients, and 5 patients underwent preterm labor. Related to heart disease, 4 patients had atrial fibrillation, 2 patients had stuck valve during the antenatal period, and 2 patients had congestive heart failure. And related to coagulation, 1 patient each had gum bleeding and epistaxis during the antenatal period. Now coming to the postnatal complications, none of the patients had any obstetric complication in the postnatal period. Related to heart disease, 2 patients had atrial fibrillation in the postnatal period, 1 patient had stuck valve, and 1 patient had cardiac arrest and subsequently expired on day 0 of cesarean. Related to anticoagulation, 1 patient had rectus sheath hematoma, which was managed conservatively. 1 patient had vaginal wall hematoma. 4 patients had secondary PPH, and 3 patients had hemoperitoneum, and 1 patient had drain side bleeding. 5 patients were taken back to the theater. Out of that, the 3 patients who had hemoperitoneum, they were taken for re-laparotomy. 1 patient was taken up for secondary PPH, and 1 patient was taken up for vaginal wall hematoma drainage. Contraceptive advice, none of 63% patients received no contraceptive at all in the postnatal period. 25% patients received LNG IUS, 1 patient received DMPA, and 10% patients underwent ligation. The mean duration of stay in patients on unfractionated heparin during first trimester was 30 days, and in the third trimester and postpartum, it was 45 days, barring 1 patient whose hospital stay was around 6 months. Our experience with antenatal enoxaparin was quite good in the terms that we had very few adverse outcomes on antenatal enoxaparin. And here is a slide which compares both low molecular weight heparin and unfractionated heparin group patients. Although the numbers in both studies is not comparable, still we can clearly see that the duration of stay in the first and third trimester is much lesser in the low molecular weight heparin group. Also, the major hemorrhagic complications and is comparable in low molecular weight and unfractionated heparin group. Thank you.
Very good evening to all. So we just sailed through the data of 46 patients who were on anticoagulants, and we managed them in our unit during their pregnancy. So as was evident in our data, 2/3 of our patients were cardiac patients who had prosthetic heart valves, unlike the Western data, where most of the patients who are on anticoagulants are usually the cases of venous thromboembolism. Though it was a retrospective data, but it did give us some highlights and the challenges and the issues that we faced. So the first and the foremost was the first trimester switchover. Usually these patients come to us in their first trimester, and we admit them at around 6 weeks or later if they come late, and then we stop their oral anticoagulants and start them on heparin derivatives. As per our protocol, we usually switch them over to the IV heparin infusion, and so which means that these patients have to be hospitalized for long, because this heparin infusion is to be continued till 12 weeks. It means longer IV access with associated fever, thrombophlebitis, and prolonged hospital stay of, as I said, of almost 6 weeks. And if we plan to offer them low molecular weight heparin in a bid to shorten their hospital stay, but of course they will need dose adjusted low molecular weight heparin and not the prophylactic or the intermediate risk doses. And for that, we don't have the facility of factor 10A assays. And apart from these challenges, there were other questions that we need to have a look upon. And can there be a way where the patients who are who are hospitalized for their valve replacement, can there be a point of contact then and there between the obstetrician and the patient? So then the patient is sensitized and feel more comfortable in reporting to us when she gets pregnant as early as 5 to 6 weeks of their pregnancy. Then the other issue that boggles us is, like, according to the most of the guidelines, we don't need to switch over if the daily dose of warfarin is 5 milligram or more or less than 5 milligram, and we switch over only those patients who are taking more than 5 milligram or 5 milligram. So is this the universal policy, or we have to take the patient into confidence and give her the notion that even if she is taking less than 5 milligrams, she is not without risk, and it is her choice whether we have to switch over or not. Then the third issue is about acetrom. Many of our patients, they are on acetrom when they come to us. So what is that critical dose below which we don't need to switch over these patients? And then the issue of subcutaneous heparin, of course, not in the cardiac patients, but in the VTE patients, can these patients be given subcutaneous heparin because they can't afford the expensive low molecular weight and still don't want to get hospitalized? And the last but not the least, the advocacy for low molecular weight heparin in our patients with prosthetic valve. For this, we'll be listening to Dr. Ambuj at the end of this presentation. For now, I'll invite the anesthesia team for their perspective in anesthesia in such patients who are on anticoagulants.
Very warm good afternoon to one and all present here. I'll be presenting basically the anesthetic concerns and the peripartum concerns of patients with who are on therapeutic anticoagulation, and also our ICU management with a special emphasis on women with prosthetic heart valves. Coming to the peripartum management, as already said, it requires a multidisciplinary approach involving various departments. The woman is counseled regarding the pros and cons of different anticoagulation choices. Then we inquire on what anticoagulation the patient was initially on. If the patient was on warfarin dose of less than 5 mg per day, we can continue the warfarin, or we switch over to LMWH or unfractionated heparin. If the woman was on a warfarin dose of more than 5 milligram per day, it is generally advised to discontinue the warfarin and to switch over to unfractionated heparin or low molecular weight heparin between 6 to 12 weeks of period of gestation, after which it can be switched over to warfarin. Then warfarin is continued through the second and the third trimester. 1 week before the delivery is planned, the woman is asked to switch over to either unfractionated heparin or low molecular weight heparin. 36 hours before the delivery, it is advised to switch over to continuous infusion of unfractionated heparin. For monitoring these three anticoagulants, for warfarin, we target the INR according to the risk factors the patient has, and also according to the type of mechanical prosthesis the patient has. We target the INR. With older generation prosthetic heart valves require a higher INR, whereas the newer generation prosthetic heart valves require a low INR. A rule of thumb for mitral valve is to maintain the INR between 2 to 3, and for aortic valve between 3 to 3.5. For LMWH, we monitor the anti-factor 10A levels between 0.8 to 1.2 units per ml, and it is advised to repeat this assay at weekly intervals. For unfractionated heparin, we target the APTT levels two times the control value. Coming to the considerations for neuraxial anesthesia, if the patient was on warfarin without any bridging done, neuraxial is contraindicated in such group of patients. Emergency reversal of anticoagulation is advised in such patients before taking up the patients for LSES. For LMWH, the last dose should be given 24 hours before the planned delivery, and the next dose should be restarted after 12 hours, provided hemostasis is secured. And if the patient has an epidural catheter in situ and planned for removal, then the next dose should be given after 4 hours. For those patients who are on UFH, the last dose should be given 4 to 6 hours before the delivery, and the dose after the delivery should be given 4 hours, provided hemostasis is secured. And in such cases, a bolus dose is not required. We can directly switch over to the infusion dose. And for epidural catheter, if it's removed, it's planned to be started after 1 hour. Now the above scenario which I already described holds good for patients who are planned for LSES. But if we receive such patients who come for emergency LSES or emergency vaginal delivery, in such cases we have to go for emergency reversal. For those patients who are on warfarin, it is advised to give a bolus of vitamin K of 10 mg, followed by either fresh frozen plasma at dose of 15 ml per kg or prothrombin complex concentrates. After this, we target an INR of less than 1.5. For LMWH, there is a limited role of protamine. However, if the dose was received less than 8 hours back, we generally give 1 mg of protamine per 100 units of LMWH. And if the dose was received more than 8 hours back, then it is advised to give 0.0 mg per 100 units of LMWH. For those patients who are on UFH, it depends upon whether the patient was receiving an IV infusion or a bolus, and also on the time interval. For patients who are receiving an IV bolus, if it's given less than 30 minutes back, it's advised to give 1 mg of protamine per 100 units of heparin. And if the dose was given more than 30 minutes to 2 hours back, it is advised to give 0.5 per 100 units of heparin. And if the dose was given more than 2 hours back, it is advised to give 0.25 to 0.375 mg of protamine per 100 units of heparin. And for those patients who are on continuous infusion, we calculate the total dose that the patient received in the last 2 hours, and accordingly we give 1 mg per 100 units of heparin. And one thing to be cautious regarding when the patient is given protamine is that it has high chances of causing anaphylactic reactions, so it should always be given slowly over 10 minutes. And the efficacy of it can be measured by repeating a APTT sample after 15 minutes. There are various complications with the use of these anticoagulants. First and foremost, coming to the maternal complication, the most feared among it can cause thrombotic as well as bleeding complication. Warfarin is considered to be the safest among all the three. The requirement of LMWH is increased, as already explained, because of physiological changes that accompanies with pregnancy, like increased GFR. Hence, it requires an anti-factor 10A monitoring SSA. And this is one of the drawback of using of LMWH. Other complications of unfractionated heparin are that it can lead to heparin-induced thrombocytopenia and osteoporosis, although the incidence of both are less. And coming to valve thrombosis rates, this data is taken from the Western population. It is found that warfarin is associated with the least incidence of valve thrombosis, and unfractionated heparin is the highest incidence of valve thrombosis. Coming to the fetal complication, warfarin use can lead to warfarin embryopathy, which is characterized by limb defects and nasal hypoplasia. However, if the woman is on a warfarin dose of less than 5 mg per day, its incidence is negligible, as low as 3%. But if the patient is on more than 5 mg of heparin of warfarin per day, the incidence can be as high as 30%, for which a switchover is required. Also, it can lead to fetopathy, which is characterized by ocular and CNS defects. The incidence is less. And coming to the miscarriage rates, vitamin K, warfarin is associated with the highest fetal anomalies, and LMWH is considered to be the safest. And coming to the neuraxial complications associated with the use of these anticoagulants, its use can lead to spinal and epidural hematoma. Although the literature search does not reveal that many cases, uh, a hypothesis which they have advocated is that since pregnancy is a hypercoagulable state, so it is a protective against the development of the above two. Coming to the specific management in ICU, antepartum coagulation, as I already described, we follow the flow chart that was discussed in the first slide. And in the postpartum period, generally we switch over the patients to unfractionated heparin, since APTT assay is easily done, and since factor 10 is not available, we do not start these patients on LMWH. And there is limited role of novel oral anticoagulants unless the patient has some documented allergy to heparins. There are few case reports with fondaparinux which suggest a favorable outcome in pregnancy. And bridging over to warfarin is completed by day 5 of postpartum period. And once therapeutic INR is achieved in such patients, we discontinue the heparin. And the duration of anticoagulation is continued lifelong for those patients who have mechanical prosthetic heart valve, and at least 3 months for those patients who have a history of venous thromboembolism. Coming to the dose adjustment, if the patient is on unfractionated heparin, we give an initial dose of 80 units per kg, followed by a continuous infusion of 18 units per kg per hour, according to the actual body weight. We titrate the APTT and we maintain between 46 to 70 seconds. And for those patients who are on LMWH, we either start them on enoxaparin 1 mg per kg BD dose or 1.5 mg per kg OD dose. And for those patients who are receiving deltaparin, the dose advised is 100 units per kg BD dose or 200 units per kg OD dose. And both these are not recommended when the create clearance is less than 30 ml per minute. And in such patients, monitoring by anti-factor 10 is mandatory, especially those patients who have a renal failure or those patients who have extreme body weight. Thank you.
Good evening, everyone. While reviewing the literature on this topic, we have a paucity of well-designed RCTs to guide us for the anticoagulation therapy for pregnant females. Whatever guidelines, clinical practice guidelines we have, they are mainly based on observation studies or they are just the extrapolation from the results in the non-pregnant patient. So as such, there is no optimal therapy as us to guide us for the therapy of anticoagulation. We have to find a delicate balance between adequate protection from a thrombotic event without causing harm to the unborn child. As discussed, we have these three options, which are vitamin K antagonists, unfractionated heparin, and low molecular weight heparin. And obviously, oral anticoagulants are known cross placenta and thus are teratogenic, and heparins do not cross placenta. We all know that the heparin-derived anticoagulants are not as effective as warfarin for anticoagulation, leaves the females more vulnerable to the thrombotic risk, which is particularly very important for in the switchover time. Warfarin, we all know, is a category D drug, although most effective anticoagulant for preventing maternal thromboembolism, but we all are dreaded of its adverse fetal effects, which are miscarriages, embryopathies, FGR, stillbirth. While deciding between unfractionated heparin and low molecular weight heparin, we have all the advantages of low molecular weight heparin. The only disadvantage is it has a longer half-life, plus we do not have any antidote to reverse its effect. So while managing these pregnant females on anticoagulation, we basically face two scenarios in our practice. One is mechanical valve and another is BT treatment or prophylaxis. While reviewing the literature, we have a very beautiful systemic review of international guidelines for the prevention and treatment of pregnancy associated thromboembolism, in which they reviewed 15 guidelines from 13 organizations, and they included 8 guidelines which were strongly recommended for use in practice, included all the major societies. All of them were in the favor of low molecular weight heparin, except for few. In special situations, they have recommended unfractionated or vitamin K antagonists. Our experience with antenatal enoxaparin, which we use majorly in the post-IVC angioplasties in HVOTO, is also good as we faced less of adverse outcome. Now the important topic, that is pregnancy with mechanical heart valves. Why it is important? Because there is annual risk of a thrombotic event without patient not on anticoagulation is 4%. So as a result, pregnancy in a women with heart valve is associated with high complications. Majority we are concerned about thromboembolic complications. The others are heart failure, arrhythmias, and bleeding complications. This is a study from our institution, our department, 20 years back, a retrospective data of 10 years, in which 41 females received anticoagulants. And in this data, which we reviewed this time, it is just 5 years data, and in one unit, we have included 46 patients. This is because of more referrals, more awareness that we are getting more patients now. This was a study, initial study done in 2004, which finally concluded that we need a double therapy which has a lowest thrombosis and death complication, which is unfractionated heparin or low molecular weight heparin in first and then warfarin. This was a landmark study which concluded that we need 2 agents during the pregnancy. Similar study in the lines, it is a recent studies published in British Journal, which compared the pregnancy outcomes with all the different regimes and with the LMWH in the first trimester and warfarin in the second trimester, they have a good maternal and good fetal outcomes in the 56% of the females. Now, while reviewing the literature, the first one is a 2011 study, retrospective study, an Indian study. They used all types of anticoagulants in their pregnancies, and mortality was comparable to our data, which is 0.94%. And in another study, which was also a retrospective study, 2015, valve thrombosis is 4.7, which is also comparable to our data. Our study concludes to be at less valve thrombosis than this study. And then we studied these two studies, which was a retrospective study in HVOTO, published in Hepatology Journal. They used low molecular weight heparin throughout the pregnancy, followed by warfarin in postpartum, which was seen that there was no mortality or thrombotic event noted in the pregnancy. While reviewing the complications with the previous studies with our data, we can see that maternal mortality is comparable or even lesser in our data, and thrombosis, which is the most dreaded complication, PHVT, is also comparable or lesser in our data, which is 2.17%. Hemorrhagic complications are comparable to this study in 2011, which is 19.5%, majorly as described with PPH, rectus sheath hematoma, and re-laparotomy. We have some guidelines to guide us. So what anticoagulation we use for the patient in pregnancies with mechanical heart valves. We have 2020 ACC guideline and 2021 ESC guidelines. I invite Dr. Ambuj sir to please guide us on this guideline.
Good afternoon, everybody. Thank you for giving me an opportunity to share my thoughts. So, before coming to the details, I mean, we need to put things in perspective. So, a pregnant lady with a mechanical prosthetic valve is a very, very high risk and a challenging situation. Conventionally, if you see, there are four cardiac contraindications to pregnancy, which we read in textbooks. It's high PVRI, pH, it is presence of aortic aneurysms more than 4 centimeters. It's severe left ventricular outflow tract um, uh, obstructions like aortic stenosis, or it is LV ejection fraction less than 30%. But if you look at the registries, and these are registries from Western countries where you have obviously far better patient literacy and follow-ups, the mortality rates, as you saw in the UK registry, was 9%. There were only 28% favorable fetal and maternal outcomes. The ROPAC registry from Europe showed a 20% mortality with favorable outcomes only in 58%. So it compares to any of those four contraindications to pregnancy. So it's obviously a very challenging case. And so to begin with, we need to counsel our patients before they conceive for the risk, both to the mother and the fetal outcomes that are there. Given the cultural pressures of our society, most of the patients, most of the women are forced or do out of their volition conceive, but they need to realize the gravity of the situation. So that's very important for all of us to understand. And as was emphasized in the beginning, we need a cardio-obstetric and even a larger team, which is again emphasized. The other point was also, which was very well brought out, but I would like to re-emphasize, is that there's the competing interests of the fetus and mother here. VKs are clearly the favorable one for the maternal outcome because they have the lowest risk of valve thrombosis, just about 4% in the worst case scenario. While if you use heparin, UFH plus VK regime, it's about 9%, 9 to 33% actually, and the 12% with low molecular weight heparin. So VK clearly is the best one for maternal outcome. While embryopathies are much more, and fetal loss are much higher again, which was shown tune of 33% when you use VK versus when you use heparin or low molecular heparin, which is 12% the fetal loss. But I think we should err on the mother because if there is poor outcome for the mother, there's obviously poor outcome for the fetus. So that is where we should err. And so I think Dr. Vidushi had put up 4-5 points to ponder. The one is a no-brainer. If somebody is less than 5 milligram of warfarin or less than 2 milligram of acetron, which is acinocomerol, we clearly don't need to switch in the first trimester. That is a given. There have been some issues raised that there might be some embryopathies even with low dose, but clearly the risk-benefit ratio is for not switching over if you're less than 5 of warfarin and less than 2 of acetron. So that is completely we must follow, and if we don't, then we are erring towards giving poor outcome for the mother. Coming to what if you heparin should be favored because easier to administer. it is easier to, the patient need not be admitted. We know uh, beds in our institutes are an absolute premium. So you need to optimize your resources so you can do it on an outpatient basis. But we are in an ideal world, we must have anti-10A level measurement. And I'm sure I have discussed this with our colleagues in lab medicine, and we should be able to do that soon, which is we must maintain a trough and peak, adequate trough and peak anti-10A levels, which should be available. But as of now, thankfully, whatever the data was shown, even without that, patients have done well on low molecular weight heparin. It's very easy to say that you can monitor UFH, but even UFH needs a monitoring of 6-hourly APTT till the patient comes into the range which is required, which unfortunately also does not happen practically. So you're able to do APTT every 6 hours till you reach the target. And every time you change a dose, you again need to do that 6 hourly. So it's very difficult to monitor that also. So we should again probably be using low molecular weight heparin, ideally with factor 10A levels. So that is what I would like to talk about anticoagulation, especially in aspect of mechanical prosthetic valve. And we should all realize, as it was very aptly said, there are no optimum treatments. They're all based on very small observational studies, no randomized trials. The data is not very robust, but this is what we have, and it's a very challenging situation, and we need a teamwork. That's all that I would like to add, and thank you.
Thank you so much, sir. So I think we are just clear after sir's talk that we need a very definite pre-pregnancy uh, counseling, early booking, close surveillance during pregnancy, a multidisciplinary team approach. I will also like to uh, invite Sir Gastroenterologist, Sir Sharma, for a few words on the gastroenterology aspect.
So, my experience with Bud Carey is been seeing them for a long period of time now, and it's very easy to say pre-pregnancy counseling. Let me tell you that we've been talking to every patient. Each one of them, you know, liver disease per se predisposes these patients to infertility. They're trying to get pregnant. Unfortunately, they don't get. It's one fine day they'll come up in the outpatient and tell you that we're pregnant. Till the time when they come to you, it's already its second or third month. We don't find them coming up very early to us. So that's one problem which I face clinically, very practical problem. You keep on telling them you would be needing a switch of therapy, but it's really very difficult practically. Other problem practically which I face is Budd-Chiari is a disease of young females. Now, they'll get married, they'll move to another place, and most what happens in clinical situations and practical situations, they won't tell their husband, their families that they are on a medication which they need to take daily. What they'll do is they'll stop medications and come up with problems. Pregnancy per se, you beautifully highlighted, is a hypercoagulable state. And if you do not continue anticoagulation, you're looking for trouble. So they're going to have problems. Then we also know that liver disease patients have varices. So, and you're all worried, and we get a lot of consultations regarding how to manage those varices. We tell them prior to conception or any female who comes, because our policy is to for stenting, as in a cardiology side, you're placing balls. For opening the veins, we put in stents over there. Keep the stent patent, you need anticoagulant. And prior to doing this, we eradicate the varices, because we know that if we don't eradicate these varices, and if a patient bleeds, it's a very difficult time to manage those bleeding from varices if the patient is on anticoagulation. So we prophylactically eradicate them. But if these patients develop thrombosis of the stent, varices are again going to grow up, and these patients are going to have bleeding. So looking at trouble again. So we've got lots of practical issues regarding management, like on the pre-counseling or say preconception side. During pregnancy, again, we face issues like pregnancy is a hypercoagulable state. You got a tendency to anticoagulation. We know INR is very erratic. INR is not a good test to monitor patients. So, and you cannot give DOACs, NOACs. We don't have safety data. Other practical problem which I face in my clinic is it's very easy to say you switch over to low molecular weight heparin. You know, each injection of Clexane costs you 600 rupees. Most patients cannot afford it. It's a very difficult task, and every time I ask a patient to switch over to low molecular weight, patient goes to the market, checks the cost, and comes back, can I not continue acetron? It's going to cost him 5 rupees a day. You're looking at 500 to 600 rupees per day. So that's another big problem we face. The other problem is many of these patients have lots of um, abortions. So that's another issue which we face in the patients with bud carry. So on the practical aspect, it's easier to say to switch. You don't get a patient at an ideal time window. Cost is a major issue in our setting. And of late, we're having a good, like in the sense is that whatever patients we send are being booked. But prior, we used to face a lot of problems. So a lot of our patients used to go out, but now things are at least good for us. Like these are high risk patients. They find it very difficult to, and outside, even physicians or say the gynecologists find it very difficult to manage. So I think we need to have little more extra beds. I know that whenever we send a patient, the patient stays for a longer period of time because they get problems. But I think we need to, and these are all precious pregnancies, and you know better than me how difficult it is, like if a person conceives after 2 or 3 abortions, how precious that pregnancy. You don't want to lose it. You want to do everything to ensure that that baby goes through and the family is happy with that. So that would be my take on that. Thank you.
I think before we end, I would also, take some comments from Dr. Mukul, who's always there for us for time of need and when we have these challenges. So give your experience, partner us.
Uh, Thank you, ma'am, for the opportunity. So I prepared around 5, 6 points to say, but almost everything is covered. So what's remaining? There's one thing called time in therapeutic INR range, which should be at least for the warfarin patients, patients on warfarin or acetron patients should be in the therapeutic INR range for 65 to 70% of their time, which is usually virtually not happening for most of our patients. Even when they are stable on their warfarin doses, this is a very practical problem which unfortunately inadequately monitored and not looked after. So many a times we see patients who are going good on a particular dose of warfarin and suddenly they come back to you with the INR of 1.2. You know that you need to change the dose. You need to check the patient again after let's say 3, 4 days, 4 days likely to see what effect that dose changes made. And since you have seen the patient with the INR of let's say 1 or 1.2, you know that for the last few days as well that INR was in the subtherapeutic range. So that is one problem with the uh, warfarin analogs. Other thing I was specifically asked to look into was why is it that enoxaparin levels be monitored in pregnancy? So this is one particular aspect. I specifically looked into that question. So most of the previous study, what they have done is that for the therapeutic doses for enoxaparin, they have used a conventional dose of 1 milligram per kg twice a day. And the studies have shown that usually at this level, at this dosage, the inhibition of the factor 10A is in the therapeutic range. So factor 10, anti-factor 10 levels are maintained in the therapeutic range at this dosage. But for the prophylaxis dose, they were using a fixed dose regime of 30 milligram or 40 milligram per kg. Total that was a fixed dose. At this dosage, almost like two-thirds of the patients were requiring those changes bring them into a what should I say, a therapeutic range for the anti-factor 10A. So what we advise our colleagues and what we do for our patients on thrombosis is patients who have had more than 6 months of thrombosis, if they are pregnant, At that time, either we say switch on to a prophylactic dose, and the prophylactic dose which is advisable is 1 milligram per kg, not the fixed dose regime. And the therapeutic dose for the patients who are active DVT or with the APLA, for them the therapeutic dose remains at 1 milligram twice a day. Those are the couple of points which I want to take. I think that's it from my side. You-
Thank you, everybody. On a happier note, despite all the nuances, we're still able to tide over and walk this tightrope and make things happen. I would really be happy to have comments and any questions and anything that we're open to this at this point. Puneet.
What will be the consensus of the house to start a pregnant patient antenatally or after delivery on prophylactic anticoagulation without any risk factors?
You mean?
With,
Well,
not a non-cardiac patient or with other risk factors, obesity.
Well, I haven't been very chivalrous as such, considering that in postpartum, her, hypercoagulable state generally regresses. I don't have experience and I've not read literature, but if you have some thoughts, we can sort of have it. I really don't see because the risks. Because if she doesn't have a risk scoring, why would I sort of? She means something which is not. Yes. No, JB, we do give to high risk. He's talking of with no risk. We do, I mean, we have no thoughts as of now, and we don't dare put in with ethics. We'll be. I think what I can say, JB, I'm sure both of us can share. Our use of postpartum, use of heparin is far too low as you see it in UK. When they are more liberal. I would say 20 years back or something when I was there, I thought that every pre-eclampsia was a routine, irrespective. So I think on our scoring, we are getting more geared up now, perhaps because we realize we see, they're not surprises, they're known mortalities and morbidities. But yes, I don't think their part of the world also uses, even with the liberty that they have to use in some low risk patients. I haven't come across. Yes. 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 See, in the CMD still, that still stands at number one. Yeah. Okay, cells. With doses less. Yeah, Aparna, you have a question.
That is not yet in so not there, like we still have a patient and switching from warfarin to low molecular weight heparin instead of unfractionated heparin in the third trimester. So that is the next step. As you are saying, we are waiting for the factor 10A levels, but in the meantime, can we do that? I mean, that is something that we really need to see.
If the lady comes at 12 weeks, then it's anyway that period is over. So it's good for her that she didn't come in contact with us, or you would have switched over. So sometimes there is a divine intervention, but that's on a lighter note. But yes, see, so there's a problem, Aparna, is if you are strictly evidence-based, then if you see the guidelines say anti-10A levels are mandatory. But as the data showed, the 12 patients on low molecular heparin, they did quite well. So I think for ease of administration, low molecular weight, of course, the cost is an issue, but otherwise is a good option. As I said, it's not that heparin is being monitored as it should be, because you need to be doing APTTs every 6 hourly. The APTT should be done within 1 hour of the blood collection. I don't think those protocols are also very easy to follow. So, there are no easy answers, but in terms of ease of administration, yes, low molecular weight scores over unfractionated heparin.
Yeah, Puneet.
Any take on routine DVT screening or DVT scan in the postpartum period? I agree with it. I have with them many times. Simple 2-point compression ultrasound that can be done.
Who's your radiology friend whom we can convince? We'll be happier. Let us know. You know the
हम लोग
win
भी कर
that.
सकते हैं मैम.
So, ठीक है, then you are बुलाने के लिए.
Bedside
Thank you
screening
so
ना?
much for all
Focus.
the. I think your candidate. You have a question? Yes, yes, please. Mike did it.
Ma'am, a lot of post-op patients that we have, patients of severe.
So, but we should know the number needed to scan to pick one DVD. That will be a big issue. Maybe we can do a pilot work on our own. Yeah, don't see in the first 5 days. We don't see it. Let's hear. JB, she has a question.
Actually, I had a patient who was a post-op patient of post-cesarean of severe preeclampsia with HELP. And because of the low platelet count, we could not start her on thromboprophylaxis immediately, and we lost her to pulmonary thromboembolism. So, do we have a platelet cutoff below which we cannot start, or?
I think Mukul is there to answer that question best for us.
a patient with a acceptable risk of bleeding. The other thing is between 25,000 to 50,000, you can at least give prophylactic doses of enoxaparin. Avoid warfarin in such patients.
So thank you very much. And of course, thanks to all our colleagues from cardiology, hepatology, and hematology for making it here for us. Thank you so much.